This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 1268, recorded on November 6, 2025. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
I can see that you have like an AIDS benefit tie there with the red symbol, right?
That's exactly what it is, right? Yeah.
It's like the first thing I could see because it's really big.
Excellent. All right, let's jump in. We got a lot to cover. I was actually thinking the other day, Vincent. I was like, I don't know. I'm not sure if I'll have anything to say.
There's always something to say.
There's always something to say. So let's start off with our quotation. The mark of the immature man is that he wants to die nobly for a cause, while the mark of the mature man is that he wants to live humbly for one.
Daniel, I spent a lot of time thinking about this quote. And first of all, it should be person, not man, right? But J.D. Salinger, what did he know?
Exactly. We should start updating our quotations, yeah.
But I don't understand. Who's the one? Himself? The person is living for himself or herself?
So it's for a noble cause, right? So the mark of the immature man, he wants to die nobly for a cause, and then the mature man wants to live humbly for a cause. It's interesting. I'm rereading Hemingway, and apparently there was an interaction. Salinger was a big fan of Hemingway. Hemingway was a fan of Salinger, but then Salinger then. Apparently Hemingway didn't live up to his expectations. He became less of a fan of Hemingway, but Hemingway still liked Salinger. And I remember reading a lot of Hemingway when I was younger. And so the whole Hemingway thing about, wanting to die nobly for a cause. And I think Salinger maybe sort of responding against that.
But it makes more sense to live if you have a cause instead of dying for it, right?
Exactly. But that's that whole, a lot of fiction is that way, like someone, dying for this cause where really, once you die for the cause, you can't continue to fight for something that's worth fighting for. So that's sort of my take on all that. And I do think we have to keep pushing forward. We don't want any of the people on our side to die while they're sort of pushing for real science. So let me put on my glasses for this next one. I have a lab. My black lab Hattie is nudging my elbow. You can see her nose.
There you go. I see a black nose. How about that?
Go back down, Hattie.
So your water has stopped flowing through the light fixture, right?
Yes. So that's a good thing. And now Hattie is in here hungry. I think she goes through life hungry. All right, but let's start off. I think this is a good article. I wanted to start with this because so actually several people sent me this way. But it's the article, and I think it's very timely, Neurodevelopmental Outcomes of 3-year-old Children Exposed to Maternal Severe Acute Respiratory Syndrome Coronavirus 2, SARS-CoV-2 Infection in Utero, published in the journal Obstetrics and Gynecology, and that's the journal of ACOG, the American College of Gynecology. And so these investigators conducted a retrospective cohort study of 8,124 live births. 18,124 live births to individuals who delivered between March 1st, 2020, March 31, 2021 within the Mass General Brigham Health System. And the exposure was getting a SARS-CoV-2 infection, a maternal SARS-CoV-2 infection. You had to have a positive PCR during this pregnancy. And then the outcome of interest, what they're looking at is the presence of any neurodevelopmental diagnosis up to 36 months after birth, right? And why am I saying this is timely? Because there's all this stuff out there about, vaccines causing autism. And here we're looking at maybe actually infections might cause neurodevelopmental issues. So among the 861 individuals who got SARS-CoV-2 during pregnancy, 16.3%. So we've got 4.8% end up getting exposed. We have 140 of those 861, the offspring, ended up receiving a neurodevelopmental diagnosis by 36 months after birth, compared with 1,680 or 17,263 unexposed offspring. So we're really going to see an adjusted odds ratio of 1.29. And the largest effects were observed in third trimester exposure. So overall, adjusted odds ratio of 1.36, like a 36% higher incidence third trimester exposures. So maternal SARS-CoV-2 infection in pregnancy was associated with an increased risk of adverse neurodevelopmental diagnoses by age 3, with effects most pronounced after third trimester exposure and in male offspring.
It's interesting that even without exposure, there's still 9.7% had neurodevelopmental issues. It's a high rate.
It is a high rate, actually. Yep.
So it gets higher with infection. It's a good question, Dan. Has anyone ever looked to see if neonatal infections associate with autism?
Definitely an area that people are looking into. And I think here it's pretty striking. Like, let's pick these numbers, right? So you got a background rate of about 10%, 9.7, and then getting COVID basically during that third trimester, you're going to bump that up to 17%.
And then there are other infections too the mother could get, right?
Yeah. Yeah. So it's really interesting, right? It's all this focus on vaccination and aluminum and Tylenol. But actually, this is pretty compelling evidence, right? That getting the infection. And unfortunately, we keep discussing, there are a lot of people out there not recommending that women have the protection of the vaccine during this vulnerable period of time. All right. This one I love, Vincent, and it was fun. I was listening to TWiV 1267.
I said on TWiV, Daniel's going to do this on Clinical Update.
Yeah, I was, as you mentioned, I was listening to TWiV 1267 at 1.5x, so I get through it. And I think, as Alan mentioned, they adjust the pitch so it doesn't sound like I'm listening to chipmunks. Just people are talking at a reasonable pace for me. And this is the article, Impact of Vaccinating Adult Women Who Are HPV Positive or with Confirmed Cervical SIL with the 9-valent vaccine, a systematic review published in the journal Viruses. And so, yes, for a deep dive, I'll leave in the link to TWiV 1267. I actually thought Rich did a really good job of the clinical stuff about all sort of the progression of the different, say, pathological abnormalities we see leading up to cancer. But here's the background, right? Infection with certain types of HPV. This virus causes anogenital, head and neck diseases. You might get warts, you might get the precancerous lesions, and then these might actually progress to cancer. And we think that almost all, if not all, cervical cancer is due to HPV. And I'm going to leave in a link to that. And actually, the majority, I'm going to say over 90% of head and neck cancers are also related to HPV. Tobacco and other things might be related as well. But here's the issue. Since we have a highly effective vaccine, almost all, if not all of these cancers could be prevented. But this is where it gets really interesting. What about jumping in after the fact when a person, maybe they didn't get vaccinated, they've got the HPV infection, maybe they've already developed cancer. Can we use this vaccine therapeutically to help the body clear the virus? And so based on this systematic review that identified a number of cohort studies with Brianne explained that well, what those are, basically grouping the people, the folks that are going to get the vaccine, people that are not getting the vaccine, they found that complete HPV remission, human papillomavirus remission, was achieved in up to 72.4% of vaccinated women. And that's compared to 45.7% among unvaccinated controls. And then vaccination after conization, right? So what that is if you think of looking at a cervix like you're looking at a bagel or a donut. And so conization is basically taking almost a cone excision. Well, it's a cone excision of the interface between the inside, the endo and the ectocervix, doing a cone resection of that. So vaccination after that conization lowered the recurrence risk by 87%. Benefit seen regardless of timing. The most significant effect was observed when vaccine administration was performed before the surgical procedure. Furthermore, HPV vaccination notably enhanced viral clearance, decreased the likelihood of repeated surgical interventions. So
it's just an amazing study. Oh, well, it's a meta-analysis of multiple studies, which led to this conclusion, which is great.
I think it really is great. And one of the discussions you guys had is, so what are the current recommendations, and will this impact the current recommendations, right? So, unfortunately, the crowd hanging out at the CDC currently is kind of anti-HPV vaccine for whatever political reasons is really what's going on here, right? And we have a vaccine here to prevent cancer, but maybe there's some idea that like, oh, if you have sex, you deserve to die of cancer. I mean, I don't understand the argument, but what are the current CDC ACIP recommendations? So vaccine recommendations. So, and these we're going to see are kind of in line with some of the other groups that I'll mention. So ACOG, American College of Gynecology, CDC, ACIP, which is what we're about to do, American Cancer Society, IDSA. So vaccine recommendations. HPV vaccine is recommended for routine vaccination at age 11 or 12, but you could actually even start as early as 9. ACIP also recommends vaccination for anyone aged 26, if not adequately vaccinated when younger. And you go ahead and you give this in a series of 2 or 3 shots, depending on the age that you start the vaccination. Now, vaccination is not recommended for everyone older than age 26, and this is where this shared decision-making comes in. So they're looking at folks 27 to 45, and then you have a discussion with your provider, and you're sort of considering, shared decision on what you're going to do. And now what we're seeing here is outside of a vaccination preventive recommendation, if you're a woman who actually has progressed, do you go ahead and get it therapeutically? And so, we don't necessarily have to wait for the CDC to give some guidance here, right? This guidance can come from these other professional organizations.
Yeah, basically, if you are older, you should just get it, because if you have infection, it will clear it most likely. There's a good chance it will clear it. And even if you have a lesion, you should still get it.
Yeah. I mean, then the nice thing is, and it was interesting, when they do the studies, right, there was this whole idea that like, oh, if you don't get the vaccine, if you wait too late, then it's too late. But what we're seeing here is it's never too late, actually. Even if you've progressed to cancer, the vaccine can boost your immune response. So
what would be interesting to do a similar study in men, right? So that was a study focused on women. So men, I don't know what the age recommendation is. I guess it's the same here as CDC, right? 45 years.
They now recognize it in men. And I think that, this study looks at cervical cancer, but what about head and neck cancers, right?
Yeah, it would be interesting to look at that. Well, penile and anogenital could also benefit. So I never got an HPV vaccine. Maybe I should. Right? Who knows what I got?
Yeah. No, you probably didn't, just looking at your age thing. Now, the thing they do have to update on the CDC website is keep in mind that HPV vaccination prevents new HPV infections, but does not treat existing HPV infections or disease. HPV vaccine works best when given before any exposure to HPV. Yeah. That's not true.
Not anymore. But I don't know. Do you have any faith that CDC is going to change that?
With the current crew, I don't see them jumping in and updating that.
But I think, and tell me if this is reasonable, people should speak with their physician and say, there's these studies and I would like an HPV vaccine. What do you think?
So there's also this bias, right? And this is why we talk about shared decision-making. And also I don't see why suddenly there's this upper limit of 45. There's this idea that after 45, you're not going to be sexually active. You're not going to have new partners. We see a lot of sex in the nursing homes.
Well, I think the 45 was the age at which the clinical trials were done.
Yeah.
And that's okay. We didn't trial anyone over 45, but these studies now, they're not trials, they're retrospective analyses, but they still are compelling.
Yeah. So if you're late 40s, you're in your 50s, you're going to be having sex. I mean, there's I think a broader picture here.
But also, even if you're not having sex, you may already be infected from when you used to.
Actually,
have
that's
sex.
true. And then you end up with your head and neck cancer, and
Right.
hey, I could have gotten this vaccine, or
you get vaccinated, you have a 75% chance of resolving the infection.
Yeah. There's a lot to be said here. So, all right. So, bird flu, really interesting article. Asymptomatic human infection with avian influenza A, H5N1, virus confirmed by molecular and serologic testing. A scoping review, they call it. This is in the title. It's published in JAMA Network Open. Now, is this really this question of can you get asymptomatic bird flu, right? Maybe you get it, you don't even know. And so, we always thought that if you're going to get it, you're going to have symptoms. Well, since 1997, more than 1,000 infections with highly pathogenic avian influenza virus among humans have been reported globally. And so the objective here was to identify and characterize reported cases of asymptomatic H5N1 virus infection among humans that were confirmed by molecular testing. And they identified 10 reports of 18 asymptomatic human H5N1 infection, including 2 with molecular and serological confirmation, 16 with molecular confirmation alone.
This is so interesting, Daniel, because in 2015, when they made H5N1 transmit through the air among ferrets,
yes,
everyone was, the fatality rate of H5N1 is 50 to 80%. And Peter Palese published an article saying there are lots of asymptomatic infections. That number is wrong. We actually had a panel at the New York Academy of Sciences, and Peter was there, I was there, and so was Michael Osterholm. And now Michael Osterholm said those data are all crap. There are no asymptomatic infections. I don't believe it. And now we see even CIDRAP is carrying that story.
That's so funny, right? Yeah, I put in a connection to Osterholm's CIDRAP. So what he can now eat crow, dead crow that died of bird flu?
He will never eat crow. But what is he to say? I don't like any of these results. That's ridiculous. Yeah. And Lori Garrett was there, and she agreed with them. But the 50% fatality rate, nobody had looked for asymptomatic infections. And Peter argued that in the countries where they have a lot of poultry farming, the people don't seek any medical care. I mean, if you're not sick, they're not going to do serological surveys. So there's clearly potential for a lot of asymptomatic infection. Which basically the point is it brings down the case fatality rate.
Yeah. No, and I think it's important to realize that unless you do like a serology study, some more studies, usually we start off with these super high, case fatality rates, and that's what it is. It's a case fatality rate, but it's not an infection fatality rate.
That's right.
So exactly maybe a little humility there from
Dr. Osterholm.
Okay. All right. So we read in CIDRAP, you ready for this? Avian flu strikes turkey farms in Dakota's large egg facility in California. So, I mean, I think particularly with the U.S. Thanksgiving on the horizon, I like to focus on the outbreaks in the turkey farm. So in Lemoore County, North Dakota, a commercial turkey farm with 24,700 birds was hit. In McPherson, South Dakota, a facility with 63,800 birds affected. South Dakota also had a detection last week on a turkey farm with 56,300 birds. Ottawa County, Michigan, 62,200 birds on a turkey farm impacted. Elsewhere, 2 large poultry outbreaks reported in Indiana. 2 flocks were hit, affecting 43,800 birds total. Last week, California's Sonoma County reported a large outbreak at a commercial duck breeder farm. And now the same county reported an outbreak at a commercial table eggs layer facility with 231,000 birds affected. So,
what's a table egg, Daniel?
I don't know, actually. You want to Google that and tell me what that is? What is a table egg? Thinking they're like eggs that you serve at the table or something.
They are fresh, unfertilized eggs sold in their shell for human consumption, as opposed to fertilized hatching eggs intended for making chicks.
Okay. All right. I mean, I guess most of the eggs we eat are probably table eggs.
Yeah, you don't need a fertilized egg.
Every so often, right? You crack an egg and there's like
Yeah.
the blood in there and you're like, oh, what happened there?
Yeah.
All right. So we hear from Israel, and this sort of touches home in the measles section now, that 2 vaccinated doctors ended up contracting measles from an unvaccinated child with measles.
Wow.
So it's not fair, right? I mean, come on. Like, we work really hard. We're trying to do everything we can to take care of folks. And now these doctors end up getting sick because people are deciding not to vaccinate their kids.
It says they contracted measles. I don't know what that means. Do they get a rash?
Yeah, I guess how sick did they get? I mean, that's the nice thing about being
it says
vaccinated.
Here, because both were vaccinated, they developed only a mild form of measles.
Yeah.
So the vaccine is working, right?
Yeah.
But they probably are taking care of the case and is getting a lot of virus spewed at them. So.
Oh, probably, yeah, the exposure's got to be quite something. But yeah, I mean, that's, you take this 2 ways. One is that's not nice that the docs ended up getting, a mild case of measles. But you also take it, hey, these vaccines work. The doctors only got a mild case of measles.
But Daniel, if you were treating a child with measles, wouldn't you wear a face mask?
So we do, because it's, it's the whole, N95, you want to use, you want to use the.
I mean, if you have a known case.
Yeah, infectious respiratory particle,
protect
transmission.
yourself, right?
Yeah. But yeah, you're not necessarily going to know ahead of time. And as we talked about previously, like, what is it? Like 30% of measles cases don't even have a rash. Like, we didn't know that. We thought, well, you always get a rash and that's when you're most contagious. And we realize now you could have measles and not even have that rash.
Yep.
And we are getting updates on numbers of cases. We're up to a total of 1,681. So that's up from 1,648 from last week. So another 30 plus cases. And if we look at Canada, we're in week 43, another 29 new measles cases, up to 5,138. And so, yeah, pretty soon. I think it'll be this month. And then in January, both Canada and the U.S. are probably going to lose their measles elimination status.
That's embarrassing.
It is.
Unnecessary. It's completely preventable.
Yeah.
But, embarrassment is, I understand, is not enough motivation. But measles can make you very sick, as we have discussed a lot.
Yeah. And in all these kids, right, that immune amnesia. So not only are we worried about what's happening right now, but these thousands of kids are got next 2 to 3 years increased risk of all kinds of problems. So, all right. So it sounds like we might be getting a little bit of flu activity. We're starting to hear some whispers, but I'm really predicting that's going to be a big thing this December. So we'll see how that kind of pans out. But we're not getting a lot of data. So we're having to keep an eye on the Wastewater Scan data to see what's happening there.
Yeah, I thought we were going to have an early flu year.
I think of that as early, kind of like starting to hit us in November and then really rocketing in December. Because what I always worry about is the post Christmas, post New Year's, or even worse is you get it in March after everyone's immunity is starting to wane.
Mm-hmm.
So I'm still going with early. And we are starting to see a little bit of uptick in COVID activity. So we'll see where that goes. But unfortunately, we don't get that nice curve, so still not. That's really why we want the government to open, right? So we can get our curve back.
That's one reason, yeah. But we'd also like safe flying in airplanes too, right?
And people to be able to eat in our country. What is it? 40 million people in America face food insecurity without government assistance. So,
and while we're at it, can we get people affordable health care? I mean, this is ridiculous.
Yeah. Well, this one I really like because this seems to be a recurring issue. And I think it's really important that at least there's one place where we can have an evidence-based discussion, right? So this is this question of to vaccinate or not vaccinate the young. So that's the question. We have this article, Vascular and Inflammatory Diseases After COVID-19 Infection and Vaccination in Children and Young People in England, a retrospective population-based cohort study using linked electronic health records published in The Lancet, Child and Adolescent Health. So the goal of this investigation is to look at the incidence of severe diseases following COVID-19 infection versus whatever COVID-19 vaccination-related adverse effects. So I just wanted to make sure, like, I don't know if I can, find out, are the bots listening, right? Because there's going to be a whole bunch of comments there on our YouTube about how we never talk about vaccine adverse events. We're discussing vaccination-related adverse effects. All right. Is that going to affect the bots, Vincent? No?
Yeah, I don't think so.
Yeah, I don't know how those actually work. But so these are the results of a retrospective population-based cohort study where they analyzed whole population-linked electronic health records for all individuals in England aged younger than 18, registered with a general practitioner with known age, sex, region of residence between January 1st, 2020 and December 31, 2022. And the outcomes they're going to look at are arterial thrombotic events, venous thrombotic events, thrombocytopenia, so that's low platelets, myocarditis or pericarditis, and inflammatory conditions. And the COVID-19 diagnosis was defined as the earliest record of a positive SARS-CoV-2 PCR, antigen test, or COVID-19 diagnosis in primary care or secondary care records. The COVID-19 vaccination was defined as the earliest documented receipt of the BNT162b2 vaccine, right? That was the dominant vaccine. So the Pfizer-BioNTech was the vaccine that was basically being used. And then they're going to do adjusted hazard ratios for all of the outcomes. Now, at this point, we don't know the results, right? So I've already decided I'm going to discuss this. So however this comes out, we have to live with the data. Hope people on the other side who sort of go into this with an agenda sort of hear. This is the way science works. You do the study and then you live with whatever the results are. So
you do the study properly, Daniel, right?
Actually, and you do the study properly to get the answer, not properly to get your answer.
Right.
Okay. So they're gonna look, and we're gonna ask this question: are the risks of vaccination-related adverse events higher than the risk of COVID? And ultimately, are you doing your best by your kids by protecting them with vaccine or not vaccinating them? So here are the results, and huge numbers here. 13,896,125 individuals younger than 18, and sort of split almost 50-50 female, male. Predominantly white, 71.7% white. You end up with 28.1% with a COVID-19 diagnosis. So first, let's go through what happens with COVID. So COVID-19 diagnosis compared with no or before diagnosis was associated with a higher risk of arterial thromboembolism, adjusted hazard ratio of 2.33, so more than doubling of your risk of an arterial clot. Venous thromboembolism, 4.90, so almost a 5-fold increase in ending up with a venous clot. Thrombocytopenia, so having your platelet levels drop, 3.64, so a 3 to 4-fold increase in that. And myocarditis or pericarditis, your risk is going to go up 3.46, so 3 to 4-fold increase when you get COVID. And this is the most striking. Inflammatory conditions, almost a 15-fold increase. So just sort of pointing out, COVID's bad, and we're talking about these are kids, right? And this is just the first week after diagnosis, and that incidence is going to actually remain elevated for about 12 months for a number of these issues. Okay. So what about vaccines? So now we've got 9,245,395 individuals aged between 5 and younger than 18 eligible for vaccination. Again, kind of the equal split you get there. We're going to end up with 6 million or 72.3% white, so sort of same demographics. 3,407,560 are going to receive vaccine. COVID vaccination compared with no or before vaccination was the only elevated risk we saw was the well-described, well-known myocarditis or pericarditis within the first 4 weeks, and that's an increased risk of 1.84. 6-month absolute excess risk for myocarditis or pericarditis was 2.24 per 100,000 individuals, after diagnosis versus 0.85 after vaccination. So I just want to repeat that, really clarify, right? So we've got all those other issues that people are getting, that the kids are getting with COVID. Over 6 months, COVID-19 infection led to 2.24 extra cases of myocarditis or pericarditis per 100,000 kids, compared with 0.85 extra cases per 100,000. So this is almost a 4-fold higher risk with infection versus vaccine. And I should also point out severity, which we don't really talk about, right? Because the severity that we're seeing with infection is much more severe, where, the myocarditis we see in most cases with the vaccination lasts less than a day, resolves on its own.
Also, they didn't do this in this study, but the first dose has the highest association with myocarditis, and it goes down further after that.
Yeah, so that's the thing too, that at this point in time, we're not seeing myocarditis or pericarditis with boosters. So the risk is close to zero, where we're still seeing all these issues with COVID. Really nice figure. There's this nice figure 3, and we can really look at arterial thrombotic events, venous thrombotic events, thrombocytopenia, myocarditis or pericarditis. You can clearly see that vaccination is much safer than letting your kid be unprotected and get COVID. And oh my gosh, look at the inflammatory conditions. Particularly the youngest kids. You look at the youngest kids here, when they include the 0 to less than 18. That's like more than a 30 adjusted per 100,000.
There's no question. In every case, the vaccine is far better than getting natural infection.
Yeah, no, so that's got to be the conclusion, because I know, for our poor pediatricians out there, parents are coming in, they've quote unquote done their own research, decided not to vaccinate. And this is a great study to talk about. Say, you know what, you're being a better parent, you're making a better decision for your child if you vaccinate them versus leaving them unprotected. Children and young people, have these high risks of vascular and inflammatory diseases, particularly high risk in the first, 12 months after that diagnosis. And the risk of myocarditis and pericarditis is much, much less than with that infection. And also the severity is significantly less.
So what's the current CDC recommendation for kids under 18?
So we do recommend, they still recommend the vaccine.
Okay. So, without any healthcare issues, right?
Well, they have that kind of caveat for, people at, at risk, increased risk. So they did sort of step it back, unfortunately.
But from 4 to 8 or 6, what is the lower limit? 6 months?
It's 6 months to, I think it's 5 years of age is the one group. And I hate to bring up the ACIP recommendations. I think it's pretty clear that the data, the science recommends everyone getting the vaccine.
Of course.
All right. Now, this comes up again also, like Paxlovid, right? So you get sick, you got COVID, you're at risk of progression. Does this dangerous medicine, this dangerous expensive medicine, is it worth giving to our patients? Oh my gosh. How many studies do we need to? How many hundreds of studies do we need to go through? But we have another one. So just to keep it fresh, real-world effectiveness of nirmatrelvir/ritonavir in preventing coronavirus disease 2019 associated hospitalization, a population-based cohort study in the province of Canada, published in CID. All right, so in the U.S. last year, we had hundreds of thousands of people end up in the hospital. We had tens of thousands of people die, right? And so the question is, could we have reduced that number of people ending up in the hospital? Could we have done something? So these are the results of a retrospective cohort study of severe acute respiratory syndrome coronavirus 2 infected outpatients between 15 March and 15 October 2022. They're using data from the Quebec clinico-administrative databases. A total of 14,756 treated outpatients were matched to controls. Regardless of vaccination status, Paxlovid treatment was associated with a 74% reduced relative risk of hospitalization.
As you'll see in the letters today, we have physicians who continue to insist that it's not necessary.
Yeah.
It doesn't work anymore.
Yeah. Yeah. And as I mentioned, this is regardless of vaccination status, regardless of age. It's across the board. So it does make a difference. So, just be honest with your patients. If your patient asks, hey, I'm sick, is there anything I can do? There is, and it's evidence-based. And so get your knowledge from the literature. Don't get it from, your favorite social media or news channel. All right. So we have some fun stuff here to close us out, sort of late phase, long COVID. Remember that whole IgG4 class switching stuff? Remember that?
I do.
They're like, oh my gosh, this is really bad. And a lot of us said, I don't know. Is it really bad? Maybe it's good. So we have the article, SARS-CoV-2 spike-specific IgG4 class switching associates with clinical recovery in long COVID, published in the Journal of Infection. It actually turns out that maybe this is good. It looks like people that class switch actually do better. So they go ahead, they prospectively enrolled 105 long COVID patients at a specialized post-COVID clinic in Tokyo, Japan, between November 2022, January 2023. All the patients meet the WHO criteria for post-COVID-19 condition. They had paired serum samples at baseline, 6-week follow-up, no reinfection or vaccination during the observation to confound things. Of 105 patients, 45.7% showed clinical improvement during the observation period. And they're doing these scores, basically calculating that improved patients demonstrated significantly lower serum IgG 1%, higher IgG 2%, and higher IgG 4% compared to the non-improvers. And there's a really nice figure that kind of breaks this down. So basically, you get this enhanced IgG4 class switching. You're going to end up with 66.7% improvement versus 40.5% in the other patterns.
Now, what about acute disease? Does it make a difference? Probably it doesn't. If it's your first infection, it's not going to come up till later. But
I mean, it does take time, and that's actually the whole class switching thing, right? Because you're going to get IgM, and then you're going to switch, and then you're going to switch to specific subclass of IgG.
Now, of course, this is an association. It doesn't mean anything, but
that is true.
I mean, it's a suggestion that IgG4 might play a role in recovery, but that you could do an experiment, but we don't have an animal model. That's the problem for long COVID, right?
Yeah, that's what you really need. You need to sort of tie this in mechanistically, right? This is a correlation. But it's certainly a correlation that, goes back to that original question, is it bad, right? Because they're pretty sure the sky was falling, like this IgG class. It was all like the anti-science, anti-vax people were like, look how bad this is. This doesn't look bad.
This was induced in the study where they said it was bad. This was induced by vaccination.
So it looks like if you're vaccinated, you have a little bit of a preferential towards this IgG4 class switching. Okay. So this may, we don't know. This might be part of the mechanism for why vaccines can help people or protect people from long COVID. So, but yeah, you're completely right. Now we need to sort of dive in. Is there any way to induce this and see if there is a causal connection here? And there are a couple of studies, this whole like microbiome, and I threw in this one, and part of it is it's a little bit confusing. So I want to sort of make sure I point out like what's going on here. So the title, right? So let's start off with the title. Efficacy of Lactococcus lactis strain plasma in patients with mild COVID-19, a multi-center, double-blinded, randomized control trial plateau study published in Infection Diseases and Therapy. Now, I hate the name Lactococcus lactis strain plasma. Because it sounds like, oh, can I get the plasma? It's like, no, this is just like a bad name.
I agree.
It's a bad name for a type of bacteria. So let's just say efficacy of a Lactococcus lactis strain. I'm going to just leave plasma out because it's confusing. So the plateau study enrolls 100 folks with mild COVID-19 during Omicron BA1 endemic period. They either get the Lactococcus or placebo in a 1-to-1 ratio. Observed for 14 days. Primary endpoint was change in score of these 8 subjective symptoms: fatigue, anorexia, headache, cough, shortness of breath, chest pain, smell, taste disturbance. They've got some secondary endpoints, included each symptom, SARS-CoV-2 viral load, and the plasma cytoid dendritic cells, the little PDCs. Am I getting that right? Am I pronouncing that wrong?
PDC?
PDCs.
Sure.
Yeah. Okay. I want to just make sure that they're not like plasmacytoid dendritic cells.
That's right. That's exactly what they are.
Okay. Plasmacytoid dendritic cells. Okay. All right. All right. So my immune, buddies are going to give me a hard time for stumbling with that. But okay. The primary endpoint did not show between group differences. However, the proportion of patients without smell and taste disturbance was significantly higher in the lactococcus group on day 13. Is sort of interesting. I'm not sure how sort of compelling this data is, but some sort of interesting stuff where people are now starting to look at, what was the microbiome when you got infected, and does that potentially affect your outcome? And are there things we can do with the microbiome to potentially help with recovery? So I want to get that out there. And preventive effective vaccination on long COVID in adolescents with SARS-CoV-2 infection was published in Vaccine. Now, I put this here because this is one of those things to have in that discussion, when the parents come in, or maybe the adolescent is involved as well. And adolescents do listen to the clinicians. There's a nice research study we did on that, and we're going to probably be repeating it coming up to see if that's changed over time. But why are we vaccinating adolescents and children? We had a list of really severe outcomes that we just talked about, but really the most concerning outcome, the highest incidence outcome, is long COVID. And a lot of cohorts we're seeing about 20% incidence, right? That's a lot. There's 1 in 5 kids get COVID. It's a month, 2, 3, 4 months later, still not back at 100%. So really the question here, straightforward study and compelling results. Participants were recruited from over 60 U.S. healthcare and community settings. The exposure was the COVID-19 vaccination 6 months prior to infection. And then the outcome was long COVID, defined using this long COVID research index. So we got vaccinated 724, unvaccinated 507. The adolescents are matched on sex, infection date, enrollment data. The risk of long COVID was 36% lower in vaccinated compared to unvaccinated participants. And what are the actual raw numbers here? So infected adolescents, the risk of long COVID was 20.7%, so about 21% in the unvaccinated, and 13.3%, so about 13% in unvaccinated, so 36% reduction. And the risk of severe long COVID, 6.1% in the unvaccinated, 4.7% in the vaccinated. So again, we're seeing a 23% reduction if you're looking really at severe long COVID.
So you should get vaccinated.
Yeah, no, just when you're having that discussion as a parent, the best thing you can do for your child to keep them safe, because we know you want to be a good parent, and this is the information. This is the truth. This is not the partisan agenda.
So today we find that if you're pregnant, get vaccinated. And if you want to prevent long COVID in an adolescent, get vaccinated.
And if you're an adolescent, the risk of myocarditis, if that's what you're worried about, it's much higher without vaccine.
Right.
So, all right. No one is safe until everyone is safe. We're in our favorite time of the year. I feel like there should be a jingle. Maybe we'll have you start singing that, our most favorite time of the year. November, December, January, we do our Microbe TV fundraiser, doubling your donations, trying to get a maximum donation of $20,000 for Microbe TV. So go to parasiteswithoutborders.com and click on the donate button.
So these conclusions today about vaccinations, Daniel, they're made based on the science. They're not your feelings about it. They are not an ideology. It's based on science, and that contradicts everything going on in the administration.
Yeah.
It's time for your questions for Daniel. You can send yours to daniel@microbe.tv. Dana writes, I listen to the clinical update every week. You keep me informed and give me hope that scientific research and public health initiatives might one day become respected again. Recently, I had several doctor's appointments. I asked each provider if they were prescribing Paxlovid if someone gets COVID. All of these doctors said absolutely not. They said that the rebound makes people sicker than just having the virus. One doctor said that COVID-19 is milder now and there is no need to take a dangerous medication. Another said if you get COVID, your body will build natural immunity and that will be good. Am I right that this is not what you think of COVID-19 and Paxlovid? I'm flabbergasted that a medical doctor thinks that getting COVID will build natural immunity, and that's a good thing. What are your current recommendations for prescribing Paxlovid?
Yeah. So the data is very compelling. We just went through another study, whether you're vaccinated, whether you're not vaccinated, if you're at risk of progression, if you're at risk of ending up in the hospital, I mean, the study we just shared, greater than 70% reduction in that bad outcome. We had hundreds of thousands of people end up in the winter in the hospital last winter, probably going to end up with hundreds of thousands of people in the hospital this winter. We could reduce that number by 70% by just prescribing Paxlovid to the right folks.
Annie writes, have rules regarding doctors writing prescriptions for Paxlovid changed in the last year? I'm asking because my husband and I, in our 70s, have for several years always carried Paxlovid with us when we travel. We recently requested fresh Paxlovid. I was told current kidney and liver functions were required. The back and forth of getting these would have put us well beyond the 5-day window to start had we been infected. As it turned out, I did pick up COVID and had to use an expired box. Any problem with using expired Paxlovid? But the real problem is seniors on Medicare and making over $63,500 a year do not qualify for any Pax's help. So this is now $1,500 plus med cost with us, with our Part D, $700 each. How are we high-risk seniors going to manage if they don't have a lot of money? As always, I'm deeply grateful for all you do to keep us informed.
Yeah, no, I mean, this is absurd, actually, on so many levels. And I'm sorry, something is broken here, right? First, the lack of education on the part of providers as just came up regarding the continued efficacy of this medicine. I don't think there's a problem with expired Paxlovid. They have to put an expiration date. And what they just kept doing was giving us stickers to put over the old one and make it sort of, good again. But yeah, as you bring up the access issues, the cost issues, you hate when that's a barrier. So,
Daniel, does Pfizer keep the price high because they think it's all being reimbursed by insurance, including Medicare?
I mean, there are people at these companies who sort of calculate this sort of cost benefit of how to make the most money for their shareholders. And I really think that drives it a lot more than, hey, we want to get access here. So,
do you know how much a prescription for Tamiflu costs, for example?
It's like a little over $100. So,
so this should be $100 too, right?
In our perfect world, it should actually be free, because just think of keeping all those people out of the hospital. So, there should be, as a society, it makes sense to keep hundreds of thousands of people out of the hospital. Just think how much that costs us as a country. And then all the people that end up in the hospital, and then, they may not work because they may be at a certain age, but then the family is now not able to work, and you're trying to take care of the kids, and just the impact of society. So we need to sort of rethink how we're doing all this.
By the way, Daniel, last night on live stream, a woman said, "I don't have a cervix. Do I need HPV vaccine?" And I said, "Well, I'm not a doctor, but there are other cancers caused by HPVs besides cervical, so you probably should get it, right?"
You've got a head and neck, right? Head and neck cancers. You got an anus.
Yeah. So that's what I told her. Okay, Sarah writes, I'm 61, and as far as I know, I never had chicken pox. I was vaccinated soon after having my first child to avoid getting it as an adult. The recommendation seems to be that everyone should get the shingles vaccine rather than trying to figure out who is actually at risk of shingles. I've been dragging my feet because I don't think I'm at risk, and there are so many reports of significant reactions to the vaccine. Now I'm hearing about other possible protective effects of the shingles vaccine. I'm thinking there might be more reason to go ahead and get it. What are your thoughts?
Yeah, go ahead and get it. But it is interesting. We'll go through this. So, there is a reactogenicity to the vaccine, right? It's protein-based. A lot of people get the shot. And this was sort of when people started with COVID shots. We're like, hey, it could be like getting that Shingrix shot where maybe like you got to plan that next day you're not going to feel so hot. But we're talking about a day of not feeling so hot. Then let's say 3 months later, another day of not feeling so hot. But then we've talked about it as the dementia vaccine. Also, if you did have chickenpox when you were younger, it is a very effective shingles preventative, which is great. So yeah, you're over 50. We do recommend it.
Philip writes, please tell us about the new Moderna mNEXSpike vaccine for 65 and older.
Sure. We talked about this a little when it came up as options, and this was actually based upon some efficacy, and not just antibody levels, but efficacy. It was about a 9% lower risk of symptomatic COVID compared to the other. It tends to have less RNA, so maybe not going to have that same cancer boosting if you're doing your immune therapy for your cancer. But yeah, so it's another option, and there is that data suggesting it might have a little bit of benefit compared to the prior Moderna shot.
So instead of the whole spike, it's mRNA encoding the receptor binding domain, right?
Yep.
Yeah. And Li Ping writes, I have a follow-up regarding shingles vaccine for over 40-year-old. The Chinese version of a shingle vaccine was tested for people 40 years old and up, provides a link to that. Efficacy and safety, a multi-center randomized double-blind phase 3 clinical trial. It's about 57% effective at preventing shingles. The Chinese vaccine is live attenuated, so different from Shingrix, but can I extrapolate the safety profile from the Chinese clinical trial, safe for 40 years old and above? Can I extrapolate it to all shingles vaccines?
So no, I mean, it's different, right? So this is live attenuated vaccine, which is similar to the Zostavax that we used to use, which is actually pretty much what we're using for the kid vaccine, right? The chickenpox vaccine for the kids. But the Shingrix is a protein-based vaccine. So we actually think of it as safer, but more reactogenicity. So yeah, you're really sort of comparing two different vaccines there. And as we talked about, when it came to the dementia studies, we actually had a comparator where it looks like the protein-based Shingrix might be better for that purpose.
I mean, Shingrix is in the 90s at protecting against shingles, whereas the Chinese, the vaccine made in China, shouldn't say the Chinese vaccine. That's no good, right? The vaccine made in China.
Yeah,
China developed is 57%. So
similar to the Zostavax.
Zostavax, yeah. That's TWiV Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you. And everyone, be safe.